Welcome to the debate. So if an anxious, coughing patient sits on your exam table and, asks you for antibiotics, is a flat, unyielding no the ultimate act of responsible medical care? Or is it a complete failure of clinical empathy?
Yeah, it is the central tension in just about every consultation room today, right? Balancing the hard truths of medical science with the psychological reality of the actual person sitting across from you.
Exactly. Today, we are analyzing the specific clinical communication strategies modeled in the Occupational English Test, or OET, follow-up consultation script. It features an exchange between a doctor and a patient, David Miller, who is recovering from a lingering chest infection. And I'm taking the position that this script models excellent, clear-cut communication, specifically regarding antibiotic stewardship and safety netting.
Mm-hmm.
It provides the definitive clarity that is absolutely essential for, both patient compliance and broader public health.
Right. While I argue that the script's heavy reliance on absolute language, using words like normal or flat out stating that treatments won't help, it dismisses the very real ambiguity of medicine. By leaning so hard into being definitive, it completely bypasses the collaborative dialogue that you actually need to address a patient's underlying anxieties and to foster genuine behavioral change.
So let's lay out the frameworks for how we are reading this text. From my perspective, the direct, definitive communication style modeled by this doctor is the ideal framework for clinical interactions, particularly in a high-volume setting.
Okay, but at what cost?
Well, let me explain. We see a practitioner who explicitly states the chest x-ray, quote, looks normal. She definitively tells the patient that antibiotics won't help for a viral infection. By doing this, she establishes uncompromising boundaries.
Right.
This clarity prevents antibiotic resistance. It ensures the patient understands the exact treatment plan, rest, hydration, continuing prescribed medication, and it just leaves zero room for dangerous misinterpretation.
I hear the appeal of that simplicity, I really do. But I am looking at the long-term cost of that clarity. The text's overly definitive framing sacrifices essential clinical nuance. Yes, the patient in the script readily accepts the blunt no to antibiotics, and he accepts the reassurance that there is no sign of pneumonia.
Which is the goal, isn't it?
But real practice doesn't often flow like a perfectly compliant script. It requires exploring why the patient is asking for those things. The blunt dismissal of medical interventions and the highly superficial handling of lifestyle changes later in the text, it represents a massive missed opportunity. You cannot simply mandate health. You have to build trust.
But trust is built on a foundation of professional certainty. Let's look at the very beginning of the encounter. The patient says he is still coughing occasionally. The doctor immediately responds by saying, I've reviewed your chest x-ray and the results look normal. There's no sign of pneumonia or any serious lung condition.
Right, yes.
That is the bedrock of good care, providing immediate, necessary relief to a fearful patient.
It provides relief in the moment, absolutely. But consider the cognitive disconnect that creates for the patient while they are sitting in the room. The doctor is describing the x-ray as unequivocally normal. Yet the patient is physically experiencing illness. They're still coughing.
Sure, but
a chest with an active viral infection is not strictly normal, right? It is inflamed. It is symptomatic.
But medically speaking, the film is normal. There are no infiltrates. There are no consolidations.
To a radiologist, yes. But we are talking about communication with a layman here. Think about it like a car. It's like a mechanic telling a driver their engine is perfectly normal while the check engine light is actively flashing on the dashboard.
Oh, come on.
No, really, technically, maybe the transmission block is fine and there's no catastrophic failure. But you haven't explained why the light is flashing. The driver knows the car is shuddering at highway speeds. If you just say it's perfectly normal, the driver doesn't feel reassured. They just think you haven't figured out what's wrong with their car.
I think that analogy misses the acute fear of the patient, though. When someone comes in worried about pneumonia, they do not want a nuanced lecture on the varying degrees of radiological inflammation. They want to know if the engine is going to blow up.
Yeah, but
by explicitly naming the worst-case scenario pneumonia and taking it off the table, the doctor clears the cognitive space for the patient to actually listen to the rest of the advice.
But you can clear that same cognitive space without using a word that contradicts their physical reality.
You simply explain what the test rules out rather than declaring the organ completely healthy. You say, the x-ray shows us you don't have pneumonia, and there is no severe pathology.
Which is essentially what she does.
No, because if you call a coughing patient normal and that cough persists for 3 more weeks, the patient is going to think the doctor missed something because they said I was perfectly fine. It creates a massive vulnerability for future trust.
You're isolating that one word, normal, but she immediately contextualizes it. In her very next breath, she says, based on your symptoms, I believe you have a viral chest infection that's gradually improving. She names the check engine light. She bridges the gap between the clear x-ray and the lingering cough.
I suppose.
And it's that exact definitive boundary setting that makes her handling of the antibiotic question so effective.
Ah, right, the antibiotic refusal. Because this is where the script's communication style really shows its cracks.
I disagree completely. The patient asks, do I need antibiotics? And the doctor replies, no. Since it's a viral infection, antibiotics won't help. That is exactly what practitioners need to be doing.
Medically, 100% correct. Pedagogically and empathetically, that blunt refusal is highly problematic. It completely shuts down the conversation. It lacks any curiosity about why the patient feels they need them in the first place. Did a previous doctor give them a Z-Pak for a similar cough 5 years ago? Did they read something online?
We are operating in the real world of limited clinical time. We do not always have the luxury of, prolonged philosophical exploration into the origins of a patient's medical beliefs.
It doesn't take 20 minutes. It takes 20 seconds. When you drop a heavy, immediate no on a patient without exploring their rationale, you trigger what psychologists call the writing reflex.
Right, yes, the writing reflex.
Exactly. You are instantly correcting them, which automatically creates defensive resistance.
But wait, she isn't just dropping a no and leaving him in a void. You're giving her a pass on the second half of that sentence.
How so?
She immediately pairs that firm boundary with a highly specific, actionable alternative. She says, the best treatment is rest, staying hydrated, and continuing the medication I prescribed. A definitive no, immediately followed by a clear action plan, is precisely how you manage a patient's expectations.
That assumes the patient is still listening after the rejection. If a patient is experiencing health anxiety, their cognitive load is already high. If you simply block their proposed solution, the antibiotics, without validating their distress, they aren't going to absorb your advice about rest and hydration. They just feel dismissed. The mechanism of communication requires alignment before redirection.
Give me an example of what that alignment looks like practically then.
Sure. You say, I completely understand why you might think antibiotics are the next step, especially given how long and frustrating this cough has been.
Okay.
However, because we know this is viral, an antibiotic will actually do you more harm than good right now by destroying your healthy bacteria. That validates the frustration, it aligns with their desire to get better, and then it explains the mechanism of the refusal. The script just issues a command.
I would argue that absolute clarity is a form of empathy. Leaving a patient in a state of ambiguity or over-explaining the microbiology can actually induce more anxiety. The patient wants to know what to do, and this directness carries right over into the safety netting phase.
Well, the doctor sets a very clear timeline. She says the cough may continue for another 1 or 2 weeks, but warns him to come back immediately if he develops a high fever or difficulty breathing. It perfectly balances realistic expectations with unmistakable red flags. It checks the safety netting boxes on a rubric, yes, but look at the psychological whiplash this creates in the room. Just moments ago, the doctor delivered an absolute reassurance. Your x-ray is normal, you have no serious lung condition, you don't even need antibiotics.
Right?
Now, suddenly, she's telling him to watch out for a high fever and respiratory failure.
But that's the reality of the illness trajectory. Things can change.
Exactly, but the transition matters. If we tell a patient their infection is gradually improving, doesn't explicitly outlining severe deterioration scenarios risk undoing the very reassurance we just provided? You can't just flip a switch from absolute safety to severe danger without a transitional framework.
I think you are vastly underestimating the patient's ability to hold 2 thoughts simultaneously. A patient can understand that a viral infection is generally benign, while also understanding that an inability to breathe is a medical emergency that requires attention. The physiological facts speak for themselves. The script doesn't waste time on overly cautious transitions because they aren't necessary.
I disagree.
And the text proves this. The patient doesn't panic. He immediately shifts to a practical concern, asking, is it safe for me to return to work?
He doesn't panic because he is a fictional, perfectly compliant character in a script. In reality, abrupt safety netting often results in the patient calling the clinic the next morning in a panic because they coughed slightly harder and thought they were developing the breathing difficulty you just warned them about.
That's a bit of an exaggeration.
It happens all the time. You have to frame safety netting as an unlikely contingency. While the normal course is to slowly fade over the next 2 weeks, sometimes secondary issues pop up. It's rare. But just to be safe, here is what to look out for. That contextualizes the danger.
Contextualizing is fine, but softening the red flags too much means the patient might ignore them when they actually happen. If you couch the warning in too much reassurance, the patient might dismiss a genuine secondary bacterial pneumonia because you told them it was rare. The bluntness ensures the safety net actually catches the patient.
Let's follow the patient's pivot to returning to work then, because that transition leads right into what I consider the most glaring superficiality in the entire consultation.
You mean the smoking cessation exchange? Because I think it's fantastic. The doctor expertly ties the advice to quit smoking directly to his most pressing symptom. She says smoking will slow your recovery. Linking a lifestyle modification to an acute, present discomfort is a highly effective motivator.
The initial hook is smart, I'll grant you that. Tying the behavior to the acute symptom is good medicine, but the follow-through is a complete failure. The patient responds with, "I'll do my best to quit." And how does the doctor respond? "That's excellent. Quitting smoking is one of the best things you can do for your health."
She is validating his stated intention.
She is validating a compliance shield. "I'll do my best" is a known conversational trap. Anyone who works in behavioral modification knows that when a patient says, "I'll do my best," what they are actually saying is, "I have no concrete plan to change my behavior, but I want to end this uncomfortable part of the conversation without sounding non-compliant."
Oh, I think that's uncharitable.
It is a polite deflection, and the doctor accepts it as a clinical victory.
You have to look at this through the lens of the stages of change. This is a follow-up for an acute chest infection. It is not a dedicated 45-minute smoking cessation clinic. By getting the patient to verbalize a commitment, even a soft one, she is moving him from pre-contemplation into contemplation. She is planting a seed.
But she doesn't water the seed. Accepting "I'll do my best" as the endpoint of that topic is clinical negligence on a communicative level.
Negligence?
Yes, you don't need a 45-minute intervention. It takes exactly 10 seconds to turn that vague promise into a concrete next step using basic motivational interviewing. She could say, "I'm glad you're motivated to do your best. Would you like to discuss a nicotine patch today, or should we schedule a brief 5-minute call next week to talk about a specific strategy?"
If she interrogates his non-committal language right there, she risks alienating him entirely. Over-medicalizing a lifestyle choice in the middle of a consultation about a chest infection can make the patient feel badgered.
Badgered? By offering help?
Yes, by pushing too hard. By saying, "That's excellent," she reinforces the positive impulse without overwhelming him with immediate demands for patches, gums, or therapy. True healthcare respects the autonomy of the patient to manage their own lifestyle once they have been given the medical rationale.
I would argue that checking a box that says "discussed smoking cessation" on a chart without offering actual scaffolding for that change is an illusion of care. It models compliance-seeking behavior, not actual health care. When you strip away the nuance to achieve the kind of clinical efficiency this script praises, you leave behind the empathy, the exploration, and the collaborative planning that actually drive long-term health outcomes. The script is grammatically perfect, sure, but clinically hollow.
Well, I think we've hit the fundamental bedrock of our disagreement here. You view the doctor's directness as a barrier to empathy, whereas I view the clarity as the very mechanism of care. I maintain that the OET script models a highly effective, streamlined approach. By using definitive language regarding diagnoses, setting firm boundaries against unnecessary interventions like antibiotics, and establishing unmissable red flags, practitioners ensure patient safety.
And my position remains that while the script covers the necessary medical checkboxes, its absolute language bypasses the collaborative nuance required in modern medicine. Exploring patient anxieties, framing safety netting contextually so it doesn't cause panic, and offering concrete support for lifestyle changes, these aren't optional extras. They are the core of the healing process.
Yet, for all our back and forth on the methodology, I think we found significant points of convergence regarding the clinical goals themselves. We both entirely agree that establishing a clear timeline for symptom resolution, like giving the patient that specific 1 to 2 week expectation for the lingering cough, is a crucial anchor for the patient.
Absolutely. Temporal boundaries give the patient a framework for their recovery. And we also agree that providing specific safety netting criteria, explicitly mentioning high fever or breathing difficulty, is a non-negotiable component. Even if we disagree on the conversational transition into those warnings, you can't ever send a patient home without a map of what a true emergency looks like.
Exactly. And that highlights the inherent tension in all medical communication. We are constantly balancing the undeniable need for authoritative, life-saving clarity with the deep necessity for empathetic, nuanced dialogue. We encourage everyone listening to go review the source material for themselves. Look closely at the exact phrasing Dr. Williams and David Miller use, and consider how you might navigate these complex clinical conversations in your own practice.
Because ultimately, every patient encounter brings unique psychology into the room, and the words we choose to deploy have profound, lasting impacts on how that patient engages with their own health.
Which brings us right back to our opening thought. In the diagnostic landscape, we might crave the clean, binary lines of an X-ray, broken or not broken. But as we've seen today, language is the real surgical tool in the clinic. And knowing exactly how direct to be and when to pause and explore the ambiguity is an art we are all still learning. Thank you for joining us on the debate.